carcinoma, and others are squamous cell carcinoma, melanoma, and lacrimal sac tumors. So how to differentiate a benign lesion from a malignant one? And the eyelashes, it is sparse here. It is more here, but not near the lesion. It is sparse, and the lid margin is widened here. And you can see some abnormal dilated blood vessels also on a closer look. So definitely this needs a biopsy, and it turned out to be a sebaceous gland carcinoma. Sebaceous gland carcinoma is a highly malignant and lethal tumor. It can arise from meibomian glands, sized glands, or sebaceous glands of caruncle, eyebrow, etc. It is seen more in females and in upper lip. It can have multicentric origin and appears yellow due to lipid deposit. So this is also a nodular ulcerative lesion. You can see lashes are not here, and the posterior border is not as well defined here, and it appears yellowish. It is a great mimicker. It can masquerade benign lesions. So if you see a chronic unilateral conjunctivitis in an elderly patient which is refractory to ordinary treatment, you can think of sebaceous gland carcinoma, vegetoid spread. Likewise, chalazion also. So in this patient, on a closer look, you can see on eversion there is a lumpy, bumpy appearance with some lipid deposits, and chalazion will never go beyond the length of the tarsal height. So you have to be careful in such lesions. And vegetoid spread demands the map biopsy of the ocular surface, that is from perilimbal area, fornices, and tarsal conjunctiva, also from the caruncle, total 17 sites. It is associated with some syndromes like Muir-Torrey syndrome, Lynch syndrome, etc., where you can have visceral or genitourinary malignancies. This is another patient with a swelling at the medial canthus, and it is a carcinoma of caruncle. This lady, elderly lady, came to us with a nodular ulcerative lesion on the lower lid, and you can see pigmentation here, an ulcerating lesion extending up to the medial punctum, but a few millimeters short of punctum, and induration is also there. So it was a case of basal cell carcinoma. So it can have two appearances: nodular ulcerative and sclerosing type. Nodular ulcerative type is a firm, palely raised nodule like this with surface telangiectasia and ulceration. But in sclerosing form, it is flat and it can have indefinite margins. So it can recur. Margins can be positive after excision, and there is high chance of recurrence, and it is aggressive. Basal cell carcinoma is the most common tumor worldwide, and location more in lower lid, followed by medial canthus, and syndromes associated: basal cell nevus syndrome, xeroderma pigmentosum, etc. This is another man he was a fisherman by profession. When he came to us, he had a big ulcerative lesion. Most of his lower lid was waxen, and it is going to the canthus and the 2/3 of the upper lid with a lymph node enlargement also. Such lesions are very aggressive. This was a case of squamous cell carcinoma. It can have direct extension also along nerves, lymphatics, and blood bone. This is another lady. She was a case of xeroderma pigmentosum, and her right eye was accentrated due to a invasive carcinoma, and now she has a nodule here. Actually, there are two lesions. So superior one is a nodular lesion with variable pigmentation and sparse hairs and some surface blood vessels. So this was a case of melanoma. It is a rare tumor. It can arise either de novo or from a pre-existing pigmented lesion. Variable pigmentation is seen with irregular borders and can ulcerate or bleed. This is another patient. He came to us with a medial canthal mass. Actually, he underwent dacryocystorhinostomy from elsewhere, thinking it is a chronic dacryocystitis. After that, it increased in size abruptly with a firm mass, and on CT scan we could see a big tumor sitting here, and it was a case of squamous cell carcinoma of the lacrimal sac. So on clinical evaluation, always ask for a history of previous surgeries. A same lesion recurring at the same site after multiple surgeries, especially in elderly, it should be sent for biopsy. Red flags we already discussed. And if you see a lesion, you have to mark its size, shape, extent, and whether it is involving the neighboring structures. As in this case, it is going to the lacrimal drainage system, punctum, and medial canthus. And always evert and see the lid. So in this patient, she came with a small nodule over the eyelid, and on eversion, you can see what is behind. And always look for fixation to the deeper tissues, palpate and see. Sometimes there will be induration which we miss on inspection. Here the mass is induration is here until the inferior orbital margin, and look for regional lymphadenopathy. And you have to suspect orbital extension if the patient is having proptosis, ptosis, or extraocular movement restriction. Check for perineural spread, and imaging is necessary if you are suspecting orbital invasion. And large tumors, systemic evaluation is mandatory. So treatment is wide excision with minimal touch is the standard treatment. In invasive tumors, excision was recommended, but nowadays with the advent of chemotherapeutic agents, the indications has come down, and targeted therapy, I think Dr. Santosh will highlight on that. And follow up, these tumors are notorious to recur, so every 3 months, 1 year, for every 6 months for 3 years, and yearly thereafter.
Thank you, Dr. Santosh Horavar, the renowned ocular plastic surgeon, to enlighten us on the topic of oncological principles to augment the prognosis.
The oncological principles to optimize outcome. Because of lack of time, I will be speaking on eyelid and orbital tumors. Manage them appropriately. As far as the ocular surface tumors are concerned, the oncological principles are not to use topical therapy when not sure. You have to be sure that the lesion that you are dealing with is ocular surface cavus neoplasia and it is not invasive before you start using topical therapy. When you do surgery, it is mandatory that you should get edge and base clearance. Then edgewell therapy should be based on histopathology, and you should always screen for regional lymph node metastasis and the use of target therapy when appropriate. Like this patient who has unilateral red eye, left eye red for several weeks, not responding to conservative treatment, and looking like this on slit lamp evaluation or magnified view, you can easily misdiagnose it as ocular surface cavus neoplasia unless you evert the lid and see. On eversion, you can see that this is the normal thickness of the eyelid. This is twice as thickened. Posterior lid margin is rounded, and pupillary gland orifices are all lost. There is loss of flashes. So this is pegytoid sebaceous gland carcinoma. This patient was started on topical interferon, thinking that he was OSSM. So unless you are sure, you should not start on topical therapy. Then about this patient. This patient possibly has a deeper invasion. You cannot think of starting topical therapy unless you are clear about the depth. Like this patient has corneal OSS, and you can see that the stroma is already involved. This is the normal thickness of corneal stroma. In this area, stroma is thickened, so he cannot respond to topical therapy. So you should select out patients who are likely to respond to topical therapy. Second oncological principle is that you should have edge as well as base clearance. When we talk about surgery, the edge clearance is always 4 mm beyond the clinically determined margins. Clinically determined margins would include rose Bengal staining and a good slit lamp evaluation. Beyond that, you have to have 4 mm margins. Along with that, you have to do alcohol-assisted keratoepithectomy for the corneal epithelial component. Lamellar keratectomy and sclerectomy are generally not performed currently, and cryotherapy to resection edge would be mandatory. Like, how do you determine the base? Determination of the edge is easy. You can clearly see that this is the edge of the lesion that is stained with rose Bengal. Beyond that, if you go about 4 mm, you're fine with the edge. But for the base, sometimes it's difficult on slit lamp evaluation. So you have to rely on imaging tools. Here you see that the lesion is limited only to the conjunctiva. That's the normal sclera, and this bubbly layer is tenous. So your plane of dissection would be episclera in this patient. So you have to use imaging where appropriate. All these 4 patients have anterior segment invasion already. Clinically, they were not determined to have anterior segment invasion. Gonioscopy sometimes may not be possible or feasible. They may have a corneal scar like this precluding gonioscopy. So unless you do imaging, you will not be sure whether they have ciliary body, iris or anterior segment invasion. So imaging should be used in ocular surface neoplasia. Patients who have scleral involvement already cannot be treated with excision alone. These patients would need plaque brachytherapy either as a secondary procedure after excision of the lesion in flush with sclera. This is one more example of plaque brachytherapy done secondarily or primary plaque brachytherapy. Coming to target therapy. In conjunctival melanoma, the role of target therapy has been fairly well established. For every mutation, there are drugs that are earmarked. And this is already known that in this particular mutation, these drugs would be useful. And some of these drugs are currently available in India. And literature is flush with articles that are appearing on the use of target therapy in conjunctival tumors. This was an example of a melanoma with anterior orbital extension resolved following pembrolizumab, and there are reports on nivolumab. This was our own patient who used nivolumab for regional lymph node metastasis. Incidentally, he also had diffuse ocular surface melanoma that had recurred from a pre-existing PAM. His eye was not treated when he was started on nivolumab, and 3 months later you can see that his conjunctiva has become completely clear, thus making a case for possible primary treatment with target therapy in patients who have a diffuse melanoma who may not be operable, or in patients who don't want surgery at all. As far as the orbital tumors are concerned, the oncological principles are complete excision of a well-circumscribed tumor, irrespective of what you think is the diagnosis. So if the tumor is well circumscribed and it is not related to any of the crucial structures in the orbit, then you should aim to completely excise it. There is no role for an incisional biopsy in a well circumscribed tumor. But if a patient has an infiltrative tumor where you cannot completely excise without causing functional deficit, then you should do an incisional biopsy, and the way to do incisional biopsy has also been established. Now, when you have a patient like this patient has rhabdomyosarcoma for sure, there is no doubt. I'm just going to show an example here. We do biopsy from the superficial part of the tumor, mid-zone and the deep zone. So we send all the 3 samples to the pathologist. We go past the epicenter of the tumor and do a biopsy. Let's see what the superficial biopsy showed in this patient. It showed only dense fibrosis. That is nothing but tissue reaction. So suppose somebody had done a biopsy only from this component of the tumor, he would get inflammation as the diagnosis, so you would start this patient on systemic steroids, right? But going to the mid-zone and deeper biopsy, you have the diagnosis very clear, that is embryonal rhabdomyosarcoma. So when you do biopsy, it is currently considered that you have to go past the epicenter or the center of the lesion, and the depth is determined by CT scan or MRI, which you already have. So how deep you go is absolutely determined by imaging. So the concepts in orbital biopsy are that we should do a multi-layer biopsy, superficial, intermediate and deep past the epicenter, estimate the depth based on imaging, and frozen section and imprint and intraoperative diagnosis may be critical. Like this patient who has the roof of the orbit missing by an infiltrative lesion which is located in the superior orbit. It could be anything, but our suspicion was eosinophilic granuloma because it was there for about 4.5–5 months already. So if you go ahead and curate it or excise it, his dura will be damaged and he'll have CSF leak, right? So we do a biopsy right from the safe center of the lesion and get an intraoperative diagnosis. Once the intraoperative diagnosis confirms that it is eosinophilic granuloma, you don't have to do any further surgery. Simply inject triamcinolone right within the lesion, and 3 months later you can see partial remodeling. 6 months later there is complete remodeling of the bone. So that is possible without any major surgical intervention in this patient. So intraoperative diagnosis definitely has a role in the management of orbital tumors. One more patient with eosinophilic granuloma where the same protocol was followed. So we should go ahead and get intraoperative diagnosis whenever we have to use it for the benefit of the patient. The next is histopathology guided adjuvant therapy. This was a patient of solitary fibrous tumor. So any patient who has solitary fibrous tumor with cellular atypia gets external beam radiation because they have a high chance of recurrence, local tumor recurrence, despite it being a benign or a borderline lesion. Especially patients of this sort, where you can see that his infraorbital nerve is involved and we have excised the nerve along with it, but he still has a chance of local tumor recurrence because the infraorbital nerve obviously goes into the inferior orbital fissure From there, it could recur. So safely, this patient should be treated with stereotactic radiation as an adjuvant measure. This is one more patient of solitary fibrous tumor who was treated with adjuvant radiotherapy. In orbital lymphoma, you don't have to do gross excision. You see how nicely this patient has responded to rituximab monotherapy. He was a case of mild lymphoma. Now about multimodal treatment. In multimodal treatment, the principle is that we do only a biopsy to confirm the diagnosis. Then we do neoadjuvant chemotherapy to reduce the size of the tumor. Then we do surgery, then radiation and adjuvant chemotherapy. So this is a sequential treatment starting with biopsy and neoadjuvant chemotherapy followed by surgery, radiation and adjuvant chemotherapy. That actually benefits the patient. In patients who have undergone primary orbital exenteration, there is a high chance of metastasis and death. This is one example of a patient with adenoid cystic carcinoma of the lacrimal gland where multimodal protocol has become established. You can see reduction in the size of the tumor following neoadjuvant chemotherapy. You can see that initially the tumor was even around the medial rectus. Now the medial rectus is fairly clear, superior oblique is also clear, and the lesion is much consolidated for us to do an en bloc excision, and that is following completion of treatment. Now what about patients who have bone invasion? This patient has clearly bone invasion. Earlier we would do exenteration and orbitectomy, right? Now we don't have to do it. We simply follow the same protocol and you can see bone completely remodeled 2.5 years after treatment. So with multimodal treatment, the prognosis of adenoid cystic carcinoma of the lacrimal gland has improved. So has it improved for rhabdomyosarcoma and orbital retinoblastoma as well. So in oncological principles for an orbital surgeon, if you adhere to oncological principles with your obviously present good clinical and surgical skills already, you would be able to provide much better vision, eye and life salvage. Thank you, sir.
For serial monitoring of the lesion.
Serial monitoring of the lesion, choroidal nevus.
Yeah.
In choroidal nevus, we use fundus photograph number 1. Second is ultrasound B scan. If it's a posteriorly located lesion, we can use OCT as well to measure the height.
Dr. Donna and Matthew for her talk on ocular surface lesions. Dr. Donna is a
Lesions. So OSSN, which is the most common one, this is an umbrella term. It encompasses tumors from dysplasia to carcinoma in situ, depending upon the depth of the tumor invasion on the epithelial cell. So morphologically, there are different variants. It doesn't matter, but the management remains the same. So sometimes the two morphological features can come together. Nodulo-ulcerative is a new form, and that is usually seen in the immunocompromised patients. So clinically, how does it look? It is limbal lesion, the epicenter being at the limbus. It is interpalpable in location, most common in the nasal quadrant, and leads in the inferior limbus. So feeder vessel, these are the dilated tortuous vessels dipping into the lesion. Then keratin, this is a plaque-like thickening on the surface of the tumor due to the high turnover of the tumor cells. Then intrinsic vascularity, this has stipple red strawberry-like appearance or like a hairpin configuration. We can see the vessels growing into the lesion. So there is a corneal component, best seen on a retroillumination. So the lesion appears like a ground glass appearance with a slightly elevated lesion with a fabricated configuration. So if you see a lesion, do a rose bengal stain, check for scleral fixation, always revert the lid. If there is a fornical extension, advise for an imaging. So AS OCT do have a major role to know the extent of the lesion as well as the depth of the lesion. So in AS OCT, you can see a hyperreflective thickened epithelium with an upright transition zone between the normal and abnormal epithelium. So these are the differential diagnoses. So the protocol is, gold standard is surgery, which is a no-touch technique, which means we don't touch the tumor so that the seedings becomes less. So we need to identify the lesion, then after that mark a 4 millimeter margin away from the tumor, then 2 millimeter on the cornea, do a conjunctival alcohol epitheliectomy, excise the tumor in toto, and after that place it on a filter paper, mark nicely, then do a double freeze through cryotherapy on the conjunctival margins, then reconstruct it with IMG. So if done properly, it do prevent the recurrence rate by 5% and metastasis by 2%. So topical therapy is very popular nowadays. So I would like to say that it is not recommended in a case of scleral or stromal corneal stromal invasion. So in our institution we follow topical interferon alpha, which we have very good results with that. So coming to the pigmented lesions, nevi, which is the most common, usually interpalpebral location with variable pigmentation. They do have feeder vessels, macro or macrocyst, which is well appreciated in anterior segment OCT. It can present anywhere on the conjunctiva. Malignant transformation is very rare. So racial melanosis or complex and associated melanosis, this is bilateral, symmetric, perilimbal in location. So the pigmentation fades from the limbus to the periphery. There can be a fornical extension. If there is an asymmetry between two eyes, keep them on regular follow-up. So ocular, congenital ocular melanosis, here the pigmentation is on the sclera or the episclera. We do have an association with uveal melanoma, so always do a fundus examination when the patient on follow-up. So primary acquired melanosis, this is an acquired melanosis, usually unilateral. It is seen in the middle age. It is a brownish flat lesion, there is no cyst, it has a peppery configuration. The importance of it is it can progress into a congenital melanoma if there is an atypia on biopsy with 46% risk. So there are usually the treatment is based on the claw cover extension. So if it is a diffuse span, then we need to do wide excision along with cryotherapy, corneal excision, then chemotherapy. Conjunctival melanoma, this is a rare but deadly one, usually arising from a pre-existing PAM or a nevus. So here you can see a conjunctival nevi in the superior fornix, superior lesion. Then as it goes by, the lesion down is more thick and fleshy and elevated. There is a multiple feeder vessels into the lesion. So this is how a conjunctival melanoma presents. So the treatment is by excision with tumor-free margins, and if there is recurrence or lymph node metastasis, then we have immunotherapy on that. So conjunctival lymphoma, this is a salmon patch appearing mass, usually subepithelial. It is a fixed conjunctival mass. It's seen in the middle age. It's usually unilateral. If it is bilateral, there is a chance for systemic association of lymphoma. So musculates it can be present like an episclera or sclera managed elsewhere, not improving and referred to us. So in such cases, there is no signs of inflammation, there's no pain, there's no tenderness. This is just a mass, but it doesn't go with steroid therapy, it keeps persisting. So treatment is a biopsy and incisional biopsy usually, followed by an external beam radiotherapy and intralesional interferon alpha and rituximab. If there is, do watch for a systemic involvement, do a thorough screening and chemotherapy in case of a systemic involvement. Thank you.
Thank you, Dr. Dona, for color mass lesions by Dr. Sheera KR from Aradhana Institute, Trivandrum. She is a BR surgeon. Over to you, Dr. Sheera.
Comes to our mind, and I'll be rushing through all these features and the salient points. First of all, the retinoblastoma, we can see the incidence of retinoblastoma in India is very high, and it's the most common intraocular malignancy in childhood. And the most common presentation is leukocoria and squint, and the other rare presentations are red eye and inflammation. And germline mutations can be seen in all bilateral retinoblastoma and 10 to 15% of unilateral retinoblastoma. And you can see the most common age group in a unilateral case it's 24 months, and in a bilateral case it's around 10 months. Retinoblastoma lesions can present as an exophytic growth or an endophytic lesion. In an exophytic lesion, the mass lesion grows towards the subretinal space, and we can see the retinal blood vessels very clearly. And in an endophytic growth, it grows towards the vitreous cavity with vitreous seeds, and the retinal blood vessels may not be clearly visualized. Coming to the evaluation of retinoblastoma, the most important thing is detailed examination under anesthesia and the B-scan from the ophthalmic side. And the metastatic workup include detailed physical examination, regional lymph node examination, chest X-ray, ultrasound abdomen, bone marrow biopsy, CSF cytology, and MRI brain and orbit, which has to be done in all cases, and to rule out a trilateral RB also, and technician 99 bone scan. These are the international classification grouping we follow, group A, B, C, D and E, and E is the extensively spread form. And when coming to the treatment of retinoblastoma, the major treatment options are chemotherapy and local treatment. Chemotherapy can be by intravenous chemo, intraarterial, periocular and the intravitreal. And the local treatment mainly by transpupillary thermotherapy and cryotherapy. And other options are radiation in the form of EBRT and enucleation. These two options are nowadays not done because of this intraarterial chemotherapy. We can salvage the eye even if it's advanced grade in many of the time. This an intraarterial chemotherapy. The catheter is introduced through the femoral artery, and the edge of the catheter is opened up into the ophthalmic artery, and the chemotherapeutic agent is injected, so that the maximum maximum chemotherapeutic agent concentration is focused in that eye affected. And so, in an advanced case also, we can attempt for the salvaging. Now coming to the choroidal nevus, which is actually an incidental finding, usually presents as flat or minimally elevated pigmented lesion. It can be amelanotic also. Overlying drusen or RPE changes implies the chronicity of the lesion, and the risk for malignant transformation is very rare in case of nevus. How can we identify the malignant transformation? The things which we have to look in each follow-up is thickness of the lesion more than 2 mm, and presence of subretinal fluid, presence of symptoms, orange pigment overlying the lesion, and the margins touching the optic nerve head or within 3 mm, and ultrasound hollowness, absent halo, and absent drusen. If any of these signs are not present, then we can safely follow up the patient annually. And if one or two features are positive, we have to see the patient every 4 to 6 month time. And if three or more signs are positive, then the patient has to be evaluated in an experienced center for the further management. Yeah, usually choroidal nevus doesn't warrant any treatment, but occasionally the nevus can present with the symptoms even without malignant transformation with the presence of choroidal neovascularization. In such a cases, patients need intravitreal anti-VEGF injection. Now coming to choroidal melanoma, it's the most common primary intraocular malignancy in adult, and 85% presents from the choroid, and primarily it's sporadic, but it can be associated with the dysplastic nevus syndrome. And the most important thing is tumor size directly correlate with the chance of metastatic spread, so early detection is very important in a case of melanoma. In the B-scan, the characteristic findings are acoustic hollowness, choroidal excavation and orbital shadowing. And in FAICG, we can see the double circulation. Yeah, retinal detachment and lipofuscin orange pigment deposition is seen in a melanoma lesion, and less frequently it can cause severe glaucoma, cataract and even extraocular extension to the orbit. Such a situation, it will be in a poor prognosis. And the common metastasis will be into the liver through the hematogenous spread. The treatment options are radiotherapy by proton beam or plaque brachytherapy with a high local tumor control and a 90% of the salvage rate. Now coming to the ocular metastasis, choroid is the most common site because of the highly vascular nature, and in case of males, lung is the most common primary site, and in case of females, breast is the most common site. Usually it presents as yellow creamy subretinal deposit, but it can have an orange color, especially in case of renal cell carcinoma, carcinoid tumor or thyroid cancers, and in brown grey color in case of metastatic melanoma. And the most common characteristic finding in an ocular mets is disproportionate subretinal fluid compared to other primary lesions. In a B-scan, we can see high reflectivity on B-scan, and in an echo dense on the B-scan picture. And in OCT, lumpy bumpy choroid with thickening of the RPE and overlying subretinal fluid. In angiogram, we can see hypofluorescence in the early phase and heterogeneously hyperfluorescent in the late phase with pinpoint leaks. So choroidal metastasis, the treatment basically is the controlling the primary tumor, and the local treatment options are intravitreal injections of anti-VEGF or intravitreal chemo agent injection, photodynamic therapy or in external beam radiotherapy. Now coming to choroidal osteoma, it usually presents as a benign intraocular lesion which is composed of mature bone cells and classically manifests as an orange-yellow plaque lesion most commonly located in the peripapillary region and typically seen as a unilateral condition in a healthy young female in the second or third decade of the life. Usually it presents as asymptomatic, but depending on the location it can rarely present as visual blurring, metamorphopsia or visual field defects. The complications of this choroidal osteoma are enlargement of the basal diameter and leakage of subretinal fluid and development of subretinal neovascularization with or without hemorrhage. The management options are observation if there is no other complications or use of intravitreal anti-VEGF agents can be used in the case of subretinal fluid or neovascularization. Now coming to choroidal hemangioma, benign vascular hematomas are there and they are classified into circumscribed form or diffuse form. Circumscribed form usually occurs sporadically and diffuse form usually is associated with the Sturge-Weber syndrome. This circumscribed form usually presents in around 4th decade of the life and mostly asymptomatic and appears as orange colored mass with indistinct borders, and in ultrasonography we can see a dome-shaped choroidal lesion with high internal echogenicity, and in FAICG we can see late leakage in FFA and a complete filling of the tumor with superimposed hypo or hyper spots in ICG. Management of this hemangiomas are in asymptomatic cases monitoring or use of oral beta blockers or laser photocoagulation and Visudine PDT can be used, and in case of resistant tumors or in case of large lesions EBRT or brachytherapy is the treatment option. Now coming to the retinal capillary hemangioma, it's a benign retinal vascular tumor sporadically seen or in association with VHL. The mean age group is 25 years. And the main characteristic finding is prominent feeding vessel and a draining vessel, most commonly located in the temporal quadrant. The most common symptom is visual deterioration. Here also the treatment include, in case of smaller lesion, observation, or in a larger lesions, laser photocoagulation can be done to the tumor and also to the feeding vessels. Other options are cryotherapy and PDT and plaque brachytherapy. In advanced cases with retinal detachment, VR surgery is the option. Now coming to vasoproliferative tumors, these are also benign tumors, can be seen as an isolated lesion or it can be seen secondary to the retinal injury, ischemia or inflammation. Basically observation is the initial treatment, and if it's vision threatening then laser photocoagulation, cryotherapy, plaque brachytherapy, intravitreal triamcinolone injection or intravitreal anti-VEGF injection or vitreoretinal surgery depending on the location and size of the tumor. Now coming to intraocular lymphoma, it can be primary or secondary. Primary means it's associated with the primary central nervous system lymphoma, and secondary means lesions originating from outside the CNS by metastasis to the eye. It's predominantly B cell in origin. OCT shows characteristic findings with the vitreous cells, intraretinal and subretinal infiltration, outer retinal fuzzy borders, PED and SRF. And in FAICG we can see initial blocked fluorescence due to the lesion with edge leak and late staining. Intraocular lymphoma, the diagnostic modality is biopsy of the vitreous and retina and flow cytometry, immunocytochemistry, interleukin detection and the ratio of interleukin 10:6 ratio and a PCR amplification. And treatment basically involves methotrexate based systemic chemotherapy and also intravitreal methotrexate injection and the EBRT. But for intraocular lymphoma, the prognosis remains poor depending on the lesion size. Thank you.
To give a talk on intraocular manifestation of systemic malignancies.
Good afternoon. First of all, let me thank KSOS Scientific Committee and Dr. Ann for giving me an opportunity to present here. So, intraocular manifestation of systemic malignancy. Intraocular manifestations of systemic malignancy is important both for the ophthalmologist and the physician to recognize, as sometimes they precede the diagnosis of a malignancy. It can affect the eye either by metastatic neoplastic infiltration, as my previous speaker has explained, or circulating antibodies causing paraneoplastic retinal degeneration like cancer-associated retinopathy, melanoma-associated retinopathy, or PITM. And it can cause a hypercoagulable state causing hyperviscosity syndromes or leukemic retinopathies and anemic retinopathies. And we all know of the toxic effects of chemotherapy which can occur in the eye. So I'll first go through a few cases. First one is a 30-year-old male with no other comorbidities presenting with a decrease in vision in the left eye. His vision in the right eye is 6.6 and left eye is 6.12. As you can see from the picture, there is an elevated lesion with the subretinal fluid around nasal to the disc and involving the disc with the RPE changes. And there is another lesion near the fovea. This is very much suspicion of metastasis, and OCT shows that there is a choroidal lesion which is pushing the retina forwards. P-scan, I don't have a picture, but it showed the classical appearance, that is a high surface reflectivity and moderate internal refractivity in the left eye. FFA in the early stages was not showing any leakage, but towards mid phases it showed pinpoint to patchy fluorescence which increased in intensity towards the later phases. So with the suspicion of a metastasis, a patient underwent PET MRI by the oncologist, and it was found that there were metastasis, there was a primary left lung malignancy with metastasis to the choroid and other parts of the body. So the diagnosis is a choroidal metastasis from lung carcinoma. So metastasis, 1/3 of the patient does not have a history of primary cancer at the time of the diagnosis, and choroid is the most common form of intraocular metastatic process. Breast and lung carcinomas for women, and lung and GI for men metastasize to the eye. So for our patient, he received chemotherapy and local radiation, and his lesion resolved. Paraneoplastic retinopathy is the second one here. They can be the cancer-associated retinopathy or CAR, melanoma-associated retinopathy or MAR, paraneoplastic vitelliform maculopathy, and bilateral diffuse uveal melanocytic proliferation. So let's go to the second case, which is actually a 32-year-old female with suspected Sjogren's on systemic immunosuppression and investigation for interstitial lung disease. She presented with decreased vision, but visual acuity was 6.6 in both eyes. The anterior segment was normal, no vitritis or inflammation, but fundus showed this sensory nodal detachment supratemporally and nasally in both the eyes. So this confirmed that there is sensory nodal detachment supratemporally, but the fovea was spared at the time of presentation. And B-scan showed a diffuse thickening of the uvea, and FFA, again from early stages there was this pinpoint fluorescence, but it didn't pool, it increased in intensity towards the later phases. Our diagnosis revolved around CSR and BKH, and the patient was given steroids. But if you look at the autofluorescence, you can see there is extensive hypo and hyper autofluorescence which is seen in the autofluorescence, which are not typically seen in acute CSR or acute BKH. So as when she presented with headache, she had an MRI of the spine which showed metastasis, and the primary was found to be in the breast, bilateral breast invasive lobular neoplasm. So that is a case of bilateral diffuse melanocytic proliferation or BIDM from primary breast carcinoma. So how do you diagnose it? It's a rare paraneoplastic syndrome that can lead to profound vision loss and benign proliferation of choroidal melanocytes. It's often associated with occult but advanced carcinoma, poor indicator, poor prognosis. So it is characterized by development of multiple slightly elevated pigmented or non-pigmented uveal melanocytic tumors. Evidence of diffuse thickening of uveal tract, which was there in our patient. Multiple round or oval subtle red patches at the level of RPE in the posterior fundus. Striking pattern on FA of multifocal areas of early hyperfluorescence, which was there, and exudative detachments, which were there in our patient. There was no rapidly progressing cataract in our patient. So this was the first presentation, and going through a lot of confusion and treatment with steroids and all, finally we diagnosed that this case of BIDM, and the patient underwent treatment with chemotherapy, and after the treatment sensory nodal detachment settled down, but then there was diffuse mottling which persisted. So what is cancer? The next one is cancer-associated retinopathy, which is a type of autoimmune retinopathy characterized by rapid visual deterioration in the setting of a distant neoplastic process. It's actually caused by the circulating antibodies against the retinal proteins in the presence of systemic cancer. Some of the times when you look at the fundus, the patient's fundus might be normal, but classically it's like a disc pallor with attenuated vessels and RPE atrophy and extinguished ERG. So management option, treat the underlying cause, then systemic steroids, intravenous immunoglobulin and various monoclonal antibodies as been described. Despite above treatment, visual prognosis remains poor. So melanoma-associated retinopathy, it's on the other hand, it is associated with malignant melanoma elsewhere in the body, and it targets the bipolar cells instead of the photoreceptors as occurs in carcinoma-associated retinopathy. So now this is another case which is a very interesting. This patient is a case of non-Hodgkin's lymphoma and on remission and presented with posterior uveitis with features of some amount of disc infiltration and disc granuloma, vitritis, hemorrhage. the string of pearl appearance, pedophlebitis like a sarcoidosis type of picture. So when it comes in an NHL patient, we definitely have to look into whether there is a relapse of the case, and the patient underwent all the systemic investigation under the care of oncologist, and she also require a vitreous biopsy to rule out lymphoma in the eye. And anyway, everything came to be negative, and then she was treated as a posterior uveitis with systemic steroids and immunosuppression. Now she is doing well. She is with us for the past 3 years. Vision is still maintaining at 6.6. So that is one thing which we have come across in literature, sarcoid-like reaction which can occur on non-caseating, non-granulomatous reaction occurring under various conditions in cases of lymphoma, which could indicate a good prognosis. So other manifestations due to malignancy are hyperviscosity syndromes, as can occur in multiple myelomas or in leukemias with presence like a bilateral CRVO type of picture with macular edema. Then toxic effects of chemotherapy we should always bear in mind, like vincristine optic neuropathy that can occur in patients on ALL, on treatment for ALL, or tamoxifen maculopathy on breast carcinoma. And this ETRA-induced or retinoic acid-induced IAH is something we see in our clinic with the neurology. When they start the patient on retinoic acid, these patients can develop disc edema, which is IAH, and these patients need to be monitored to see whether the disc edema is developing, and accordingly they titrate the dosage of retinoic acid. So to conclude, a wide array of ocular manifestations can occur with systemic malignancy, and many a times we are not only the ophthalmologists, we are the diagnostic physician too. Keep our eyes wide open to see if there are any of these features suggesting any underlying malignancy. Do the relevant investigation and do the timely referral. Many a times it will not only save the vision but also the life of the patient. Thank you.
Optic nerve tumors. Thank you, Dr. Ann, for including me in this session. Optic nerve tumors are very rare. These are the common tumors we see, that's optic nerve sheath meningioma, optic nerve glioma, and metastatic lesion. So I will be presenting few cases which I saw in our institute. So here, 30-year-old male who presented with mild proptosis and blurring of vision, and his special acuity was 6/12, and there was RAPD, and frontal examination showed disc edema, and left eye was normal, and field showed inferior altitude defect, and in imaging we can see there is enlargement of and there is lesion in around the optic nerve, and in CT scan there is tracking, which is suggestive of meningioma. Since he has useful vision, he was under observation. He did not opt for any intervention also at that time. And ideal treatment may be common if radiosurgery. The advantage of that is that reduces or arrests progression. But when he came after 10 years, there was loss of vision, and the tumor also extended beyond orbital apex. Now I think he underwent surgical excision. There is octociliary cells and opticus pallor, and MRI showing lesion involving up to optic orbital apex. Not willing for any intervention. Then again, when she came after about 10 years, that lesion was extended beyond confirmed case of meningioma. Here, wide excision was done. There was erosion of roof of orbit. This patient presented with mild blurring of vision. When we examined, there was mild proptosis, and visual acuity was 6/24, and there was hyperemia of optic disc, and imaging showed there is enhancing lesion. And for this patient, common F radiosurgery was done, and he is under follow-up. The lesion is remaining. Initially, it was remaining stable. Now it is reducing in size, and vision is also improved to 6/12, 6/9. And this girl presented with proptosis and loss of vision,
and imaging showed huge lesion in the orbit, which is again fusiform enlargement of optic nerve suggestive of optic nerve glioma. Again, she opted for common ablative surgery. We could reduce the progression, but vision has reduced to PL negative. But the lesion has reduced in size and proptosis also reduced. And this child presented with severe proptosis, and there is intracranial extension, and she was treated with chemotherapy, that to palliative chemotherapy, advised palliative chemotherapy, but she lost follow. And this patient presented with again mild proptosis and decrease in vision. That I saw her in 2014. At that time she was just advised observation. Then when she presented in 2020, there was improvement in vision and decrease in proptosis, and visual field also there is improvement. So there are few reports which says that there is spontaneous regression of optic nerve glioma. So this is a patient of optic nerve glioma which regressed spontaneously. And metastasis also can happen in the optic nerve. Here we saw one patient, that 61-year-old lady, known carcinoma breast patient, and he completed chemotherapy, presented with loss of vision. So when we examine, there is optic disc edema, there is pallor, and B-scan also we can see there is enlargement of optic nerve head, and in CT scan there is enhancement of optic nerve, and in the coronal section also we can see enlargement of optic nerve. So it is metastatic infiltration of optic nerve head. So we have to evaluate for systemic metastasis, and it is again poor indication of poor prognosis. She was given palliative chemotherapy and radiotherapy. So optic nerve tumors are rare. We have to evaluate them and treat accordingly. Thank you.
Who was seated in oculoplasty interest in all of us in LF and as well as in Kerala. Her topic is on orbital mass lesions.
I will just go through some of the lesions that we have encountered. It does not include all the lesions that only some of them. The time was only 6 minutes or 8 minutes. So according to Little Flower statistics a long back, so inflammation, lymphoid tumors were the most common. And this was a case of mass lesion presenting in a man who was working in the Gulf. And CT scan showed he had there were parts of bone missing in the sinuses, and he had gave a history of fest done. So, and this was a very hard mass which was removed. The ENT surgeon removed the ENT part, and we removed the orbital part. And it was a fungal granuloma, aspergillosis. It's a very hard mass usually. So, sclerosing idiopathic orbital inflammatory disease is a new entity where you get again a very hard mass which is adherent to the structures. It has calcification and it erodes the bone, but the movements are well preserved. So it can occur even in small children. So this is a IgG4 positive orbital mass. So histopathology will show fibrosis and lymphoplasmacytic infiltration. But there are certain criteria for diagnosing a IgG4 related orbital disease. It's called IgG4-ROD, related orbital disease. The serum IgG4 should be raised. There should be more than 50 IgG4 positive cells per hypound field. So this is again a 45-year-old male who presented with the proptosis of the left eye. There was a mass in the superior orbit. So according to the CT, what is the diagnosis? What is the diagnosis in the CT? It's a molding mass, lymphoma. I thought it's a lymphoma, but the histopathology showed emperipolysis, that is presence of intact lymphocytes within the cytoplasm of the histiocytes. So the pathologist gave a diagnosis. It was CD68 and 600 positive. gave a diagnosis of Rosai-Dorfman disease, and it was published along with the RCC paper. So this was a case of a very bone eroding mass. This was many years back. The CT is not that clear. Bone eroding mass with a soft tissue component. The bone zygoma is almost totally destroyed, and there was a discharging sinus at his lateral canthus. So this was biopsied, and it turned out to be orbital tuberculosis, and it completely resolved with anti-TB drugs. This case again was a non-homogeneous mass in the lacrimal gland area. So this was biopsied, and there was palisading pattern necrosis, and there was suspected fungus. We sent it to Shankar Netralaya. The fungus was negative, but when they did a PCR visit, it was positive for orbital tuberculosis. So orbital tuberculosis can present in many ways. This was again a hard mass in the inferior orbit. That is why the orbit is called a Pandora's box, because when you open up anything, the diagnosis can be anything. Again, a hard mass producing a hypertropia, and the histopathology showed non-necrotizing inflammatory cells. That means it is not a tuberculosis. And there were Langerhans giant cells which are seen. It was an orbital sarcoidosis, and we had to give him systemic steroids for a long time, nearly 1 year, in collusion with the pulmonologist for the lesion to disappear. And this was a cyst, a hard, thick-walled cyst with layered contents, and it presented as an abscess. Somebody had did an IND for him already. It was a dermoid, a deep dermoid in the medial orbit. So this lady presented with a swelling in the temporal area. She also had a history of some surgery which was done many years back, and CT showed a mass, a cystic mass, which was the Hounsfield units were consistent with the fat in the orbit, and it was through the tunnel in the lateral wall. It was going to the temporal area. So this is a what type of dermoid? Dumbbell dermoid. It's a dumbbell dermoid. It's there inside and also outside. Again, a mass in the superior orbit with bone excavation, and it was a huge mass in a young child. Bone excavation means it has been present for a long time. As also the small mass in the anterior to the septum in a young boy. It was a schwannoma with positive antony B and A cells. This lady presented with a huge mass behind the retrobulbar, which is nearly pushing the eye out, and turned out to be a fibrous histiocytoma, or it's called a solitary fibrous tumor now, SFT, solitary fibrous tumor. This was a bilateral lacrimal gland mass. This was a young lady who was lactating, and she had a 1-year-old child. There were foam cells with lymphocytic infiltration and two-tone giant cells, which are characteristically seen in xanthogranuloma. Which is a xanthogranuloma. The mass will be slightly yellowish in color. So that is the indication. Xantho means yellow. A bone eroding mass in a child, you would have seen Dr. Santosh's slides. There were plenty of eosinophils, plasma cells, degenerated blood elements, and giant histiocytes. Eosinophilic granuloma, which is a localized form of Langerhans cell histiocytosis. Again, this child came with a history of fall. You can see the abrasion on the skin. There was a hard mass in the inferior orbit extending to the cheek. It was biopsied, and it was a primary neuroectodermal tumor. All these diagnoses are given by the pathologist. We can just biopsy and either excise the mass completely if it is completely excisable. If it's a friable mass, just do an incision biopsy. This was again a bone eroding mass in the left orbit, superior orbit, and it turned out to be again a primary neuroectodermal tumor. The patient has expired. He was treated at Vellore. A unilateral proptosis with a retrobulbar mass in a young child. Always suspect rhabdomyosarcoma or even any of the hematology tumors. So always do a fundus examination, look for rock spots, etc., and do a peripheral smear to rule out leukemia. This was a punched out lesion in the bone with the soft tissue component in an old lady. What is it, punched out lesion? was CD138 positive. It was a plasmacytoma, which is a localized form of multiple myeloma. Again, a squamous cell carcinoma, which is extended to the orbit. The treatment is excenteration. This is a molding mass in the superior orbit, and what will be this thing? It's a lymphoma. After radiation, the mass is completely resolved. Such cases, you just need to do an incision biopsy. Again, it can occur in the lymphoma can occur in the lacrimal gland alone. Bilateral lacrimal gland masses, you should think of differential diagnosis: lymphomas, leukemia, sarcoidosis, Sjogren's disease, tuberculosis, Wegener's orbital inflammatory disease. These are all the things which should go through your mind if there is bilateral lacrimal gland enlargement. A rounded mass with bone excavation in the lacrimal gland fossa. It was a pleomorphic adenoma of the lacrimal gland. It will be confined to the lacrimal gland fossa. A mass which is extending beyond the lacrimal gland fossa with bone excavation. It was an adenocystic carcinoma of the lacrimal gland. Again, a lacrimal gland fossa mass which we thought was a pleomorphic adenoma with recurrent episodes of pain, redness. There was a bone excavation but no bone erosion. This turned out to be, there were sheets of abundant eosinophilic cytoplasm, microsis with eosinophilic secretion, and this turned out to be oncocytoma. So some rare tumors also occur. You need a good pathologist to diagnose them. Cavernous hemangioma can present as a retrobulbar mass, especially in females. It can increase with pregnancy, and it's a very fleshy tumor which can be very easily removed. But a hemangiopericytoma can be very huge, and it can be benign or malignant. If it's malignant, you do not leave anything behind, or after that you have to give radiation. A young child with rapid increase in proptosis with subconjunctival hemorrhage and multiple fluid levels and cystic lesions seen in the orbit could be a lymphangioma. Lymphangioma is a clinical diagnosis. You need not always biopsy it. Multiple cystic cysts will be seen. Microcysts and macrocysts will be seen. Thank you.